Hello, everyone. Thanks for joining us. Welcome to our webinar, Supporting Students with High Acuity Needs in Higher Ed. I'm Sarah Shepard, Head of Content Marketing at Mantra. I'll be in the background assisting with technical difficulties, answering questions. We have a great group of panelists today. I'm excited to get this discussion started, but first I want to give just a little bit of housekeeping. We will record this, so it will be sent to everyone who RSVP'd. If you have any questions, please add them to the Q&A. We're going to try and answer them at the very end. And obviously we'll be on chat. Please feel free to introduce yourselves. We're excited to see who's here and what you're excited to talk about. We have a post-event survey at the very end. If you can fill it out, it helps us just plan next events. It takes less than a minute. But let's get started. So I'm going to pass it over to Dr. Chugani, who's going to moderate the discussion.
All right. Hi, everyone. I'm Carla. I use she and they pronouns. And thank you so much for joining us today. I know that this can be a very busy time of year for many of you. And so thanks for choosing to spend an hour with us. I'm Carla Chugani. I'm the Vice President of Clinical Programs at Mantra Health. And what that means is that I get to oversee the clinical design and quality of all of our products and services. I am a student affairs girl at heart, though. I started my career in a college counseling center. Clinically, I am an expert in DBT, and so I have a lot of background and experience in working with some of our highest acuity students, and that's always been really my passion as a clinician. That said, we have the most incredible panel of speakers today, and I'm sure that's who you've come to hear from. So I'm going to pass the mic around just so that everyone can introduce themselves, and then we will jump right into the discussion. All right. So Hillary, would you mind giving a brief introduction?
Thank you. I appreciate that. Yes, I'm Hillary Jones. I use she, her pronouns. I am the Director of Acute Mental Health, Crisis Response and Care Management at University Health and Counseling Services at Case Western Reserve University. Very grateful to be here today. Thank you.
Fabulous. And Daniel.
Hi, everyone. I'm Daniel Eisenberg. I'm a professor in health policy and management at UCLA and one of the PIs of the Healthy Minds Network, where we do a variety of projects, including the Healthy Minds survey study of student mental health. Thank you.
Yeah, love the Healthy Mind study. The best. All right. And last but definitely not least, Jeff.
Hi, everyone. Good to be with you today. Recently retired from a 42-year career in higher education. I spent my first 3 years as a high school guidance counselor in a junior senior high school, my last 34 at Fordham University, the last 27 of which I was the senior student affairs officer, senior vice president for student affairs with broad oversight for all of student life, student services, dining services, and athletics. So.
Thank you. Yeah, and so for folks in the audience, you'll notice that our panelists have incredibly different professional backgrounds. And we did that on purpose because when it comes to managing the needs of this particular student population, this is not something we do by ourselves in a silo, right? It requires a team-based approach. And so we want to be following evidence-based practice. We want to be following what the literature tells us. We need to be able to collaborate really well, in addition, between our clinical teams and our administrative leaders. So that's how we came to have this phenomenal panel. So I want to kick it off just with some context setting here. What trends are we seeing in terms of the severity and duration of high acuity mental health cases on campus? Daniel, would you mind kicking us off?
Sure. And the first thing I want to say is that it's actually really difficult to do research and collect data on this topic. So I think we have a pretty limited window in terms of actual hard numbers about the number and severity of student mental health crises. So just a couple of numbers that are related, but not exactly what you're asking about. We know from our Healthy Mind survey study as well as the National College Health Assessment, that there's been a rise in mental health symptoms and suicidal thoughts and attempts among the college student population. So, for example, in our Healthy Mind survey, we've seen that going back to around 2010, it was around about 0.5%, so 0.5% of students who were reporting a suicide attempt in the previous year. And in more recent years, that's risen to almost 2%. So it's risen by more than twofold. Of course, at the same time, the access to services and use of services has risen also by about twofold. So we're seeing increasing distress, increasing number of cases, which sometimes lead to crises, but also I think an increase in support that's being offered and received.
Okay, so we are gearing up our supports, hopefully in tandem with the rising need. Hillary, wondering if you would like to weigh in as somebody who's really like on the ground doing this day in and day out.
Absolutely. Yeah, I've definitely seen a lot more. And what I can't decide on, still trying to kind of suss out, is are students disclosing more than they used to in the past? Because now there's less of a stigma around mental health, and not for everybody, not across all, identities or intersections or anything, but there has been less of a stigma. And so there is a part of me that wonders if that's just why we know more, because we have that info. But then if that wasn't the case, definitely have seen a lot more students coming in with higher levels of anxiety and depression. Um, a lot of students have been coming in having already received pretty intense higher levels of care prior to even coming into college their freshman year. And so whenever I see that, I'm anticipating that student likely is going to need additional supports throughout all of the various transitional times as well. But definitely an increase with depression, anxiety, suicidal ideation, and some other serious mental illnesses.
Yeah, absolutely. So with that in mind, that this is a problem, it is not going away. I know that there are a lot of questions in folks' minds about, how do we best respond? And so the way that we've structured this discussion today is that we want to talk a little bit about, what can we do to support, you know, these students in persisting in their degrees. We will talk a little bit about risk mitigation and liability, which has been an increasing topic when we think of these students. But we also want to spend a good chunk of time talking about support systems, not just for the students, but for all of the folks on campus that are serving these students, because it's scary and it's hard work. So starting with the question of, how are we managing these situations on campus? I'm wondering, Jeff, if you could kick us off with some discussion about, what are the risks and challenges of involuntarily removing a student from campus for mental health reasons versus the risks and challenges of not having them transition off campus when something like this is going on.
Sure. Thank you, Carla. And I would pick this up by underscoring what Daniel and Hillary have said, because that's exactly the trends that we used to see, and it would bear out in our annual assessments of our own student population. And so picking up without repeating what they said, a lot of this conversation begins in the admissions process, and it continues into the summer orientation process. And you want to make sure that the greater number of students coming in who are more inclined to go seek services are going to know where to go and how to access those services. And and then going directly to your question, Carla, obviously you want to do everything you can to keep your students engaged and to keep them on your campus. And there's a lot of good reasons for doing that, that we can get into later. You're going to come across some circumstances where it may not be in the best interest of the student to remain on campus. It may not be in the best interest of the institution, and there are competing tensions there. So I think you have to have a pretty well-developed and clearly articulated processes for students to exit and re-enter. And to the extent possible, you'd like that to be voluntary. It's the decision that you reach with the student and the family, but you're going to run into some very difficult situations where it's not going to be voluntary, but based on your judgment, it may be the best thing for the student. And I think that everybody here would probably bear me out. There is no crystal ball. You're going to make the best decision you can, the best judgments you can based on the information you have. And then I would say clearly and developed and well articulated processes that have metrics and mile markers and timelines. And I would say that to the extent possible, there are always going to be some administrative obstacles to voluntary and involuntary a leave of absence and for reentry. But to the extent possible, you should remove as many of those obstacles as you can to make it easier for students and families to make good decisions that are in the interest of the students. So what do I mean by that? I mean policies around, financial questions, refunds, policies around academic withdrawals from classes, and policies around reentry that remove some of those barriers and obstacles and make it easier for students to come back in. So everybody's got well-developed refund policies and well-developed academic withdrawal policies from classes, but sometimes circumstances might suggest that you deviate from those policies in the interest of the student, the best interest of the student, and make it easy for them. You don't attach financial penalties and academic penalties for students that are going to leave because their circumstances are such that it's in their best interest to get some help someplace else. So, and we can unpack some of that later to the extent that folks want, Carla.
Yeah, I love what you're describing there about, what can we do on the front end to make it easier for students to make healthcare choices that are aligned with what they need without penalizing them for having healthcare needs. I'm also wondering if we could discuss a little bit, maybe Hillary, if you could weigh in on this question, and then I might throw a curveball if anyone's up for that. Um,
Always.
Always, yeah, me too. So what guidance can we offer for campuses that are weighing those pros and cons of, this question of, do we really try and hold these students on campus versus encouraging more of a medical withdrawal type procedure? Versus, maybe we do it all on a case-by-case basis, because from my experience as a clinician, I saw students who never got better until they left campus because it was like the stressors of the campus were taking up all their spoons, to be quite frank, and they just did not have the bandwidth to really participate effectively in therapy until they left campus. But I've also seen it go completely the other way, where that degree program or that goal, that career that flows from that degree program is their life worth living goal, right? This is a number one reason for living, and taking it away is perhaps really going to be detrimental. So how do you advise folks to weigh the pros and cons and come up with a procedure or policy that actually is going to be flexible to all the different situations that your students might present with?
Oh, that's a big question. There's so much nuance, I think, in each situation that I feel like there's a little bit of room for both. We need to have some good general policies in place, but then also there should be room for some nuance as well for the individual students. And so those policies are going to look different, I feel like, from every institution. There's going to be different expectations, different programs. At Case Western, our campus is about 50-50 graduate professional students and undergraduate students. So what our grad students might need in, say, medical school, if they're on clinical rotations, what they need accommodations for might look very different from, say, like a first-year undergraduate student. And in general, each school should have some good policies in place. I believe that, in a sense, outline like, hey, these are the things that will help you to remain eligible for enrollment. And that can look different depending on the school, whether it's different institutions in general or different programming schools within those universities. there's just so much nuance to it. But you could have situations where I think you have to look at the whole person holistically. What does it look like if they were to leave? What does their care look like? What does their support system look like if they were to leave for a medical withdrawal, or if we were to stay and try and really piece some things together so that they could have, if the student has all the supports that they need on campus and they don't have any supports when they leave campus, I want to try and advocate as much as I can for them to be successful all the way around on campus. And then the same might be true if they're willing to go home. They have great support at home. That's going to be an easier conversation as well. So it's a little bit of both, I think. I'm happy to divulge more if you need.
Yeah, well, I mean, and what I hear in what you're describing and what Jeff has described as well, um, is that in order for us to be able to offer that kind of thoughtful support and care to students, our staff and decision makers need to be given space and time and support to actually do that work. Right. So it's
100%.
not just that you can have all the policies and procedures in place, but there's also this reality that you need to be aware of, that having really clear policies, which is absolutely fundamental, is not going to save you from having to do that nitty gritty problem solving, risk assessment, decision making, holistic, care perspective.
Absolutely. Sometimes it feels like the policies are almost like the guardrails. Like that's
Yeah.
like our last line, and you keep functioning within those. Absolutely.
So you said you're up for a curveball, so I'm just going to throw a quickie. Someone had emailed us in preparation for this webinar, and they were asking a question specifically around, what do we do when we have a high acuity student? Maybe there is some stuff that's happening that's perhaps disruptive on campus. But the student is not actually willing to participate in supports such as counseling. The reason I wanted to slot that in here is because I think it hits sort of the issue we're discussing, in terms of like, well, what do we do when we're trying to support someone and they maybe don't want to access those supports?
Oh, this does get tricky. So I'm going to start to answer, but everybody just hang on a second. I think this is when you have multiple departments on campus that are getting involved in the support and in the decision making. And one of those departments on campus is likely the student conduct side of things. Not because the mental health issues or anything that needs to have the conduct piece, but if somebody is choosing to like not to engage in care, that doesn't mean that the behaviors are just like, okay, this is something that we can do. And so sometimes that's when conduct comes in, and they might have to say, hey, we respect you, do whatever you want. This isn't about any of those diagnoses. We're talking about these behaviors. You can't say X, Y, or Z and distress your whole dorm room, right? Like you can't get all these people all upset. So like we have to work on the behavior mitigation when there is the campus and community impact. And then with the students not following that, then they follow that conduct process. Um, I always talk to our student conduct department and really encourage them to talk about how helpful it can be for students to engage in services and support to get connected to care, because so often our students don't know what they don't know in terms of what actually could be helpful. And so I spend a lot of time actually educating that department and other departments as well that might have that touch point first, that maybe that will be the voice that gets into the student's ear to say, okay, maybe there's a different way I could interact, or maybe there's a different way for me to receive support. It doesn't have to look like X, Y, or Z. But it makes a lot of folks nervous to bring up the conduct piece because we don't want to discriminate. We don't want to penalize anybody for having a problem, right? Like we're all allowed to be unwell. And everybody else also has a right to be able to receive their education too. So it's a tricky balance.
Well,
I think it's oh, go ahead. Sorry.
I would jump in and just underscore Hillary has it exactly correct. I think that you need policies, but that doesn't remove, as Carla noted, the need to make judgment calls. And sometimes you have to get outside your policy and balance the need to be consistent and to be, pay attention to the individual circumstances. But I think Hillary has it exactly correct. This is a teamwork approach. The counseling center is not on an island. It exists within a network of support. There are a lot of different voices. I think everybody realizes that mandated counseling really doesn't work. Most clinicians would tell you that, but I think the student contact piece is important. And sometimes that's the tough love piece that is operating in the interest of the student when they don't want to operate in the interest of themselves. And the parents don't always react well to that. But if, as long as there's always going to be a firewall between the dean of students and the counseling services folks on a whole bunch of different issues, but there's room for a lot of good collaborative work in there where they can run interference for one another and help one another in really constructive ways, keeping the interest of the student in the forefront of their mind. And sometimes, that voluntary versus involuntary leave of absence becomes a short-term conduct related suspension for the really difficult cases when people will not get the help that they need. So I think there's room in here for lots of collaboration.
Yeah. Yeah. And it just, what you're describing, I think resonates with me as a DBT therapist, because we're so behaviorally focused and very much, of the mindset that logical consequences are important, because that is part of how learning occurs. And it is often not in somebody's best interest necessarily to protect them from just the logical consequences of behaviors that they're engaging in their environment. Anyway, we're not here to talk about DBT today, so I'm going to keep us moving and get into some risk mitigation questions now. So one of the things that I have watched, as I'm sure all of you have as well over the course of our careers, is a shift to a big focus in our culture on risk mitigation, on documentation. And I'm wondering if anyone wants to weigh in a little bit on how this focus on mitigating risk, specifically for the institution, affects our ability to support higher risk students.
I can jump in on that quick. I think you're always going to be balancing the needs of the students and the families versus the institutional needs. And if you do this work long enough, you're going to be surrounded by risk managers and lawyers whose job is to protect the institution, but your job is also to keep the needs of the student in the forefront of your mind. So documentation is important, and you do get those situations where that's where the involuntary and the voluntary leave of absence comes into play. Because there's, a lot of it depends on your assessment of the family dynamics. Some family dynamics are really functional, some are really dysfunctional. And there are families that would rather have their kids on your campus because it's easier for them to say out of sight, out of mind. It's harder for them to deal with students who are having some issues when they're at home in their living room. But they'll also be the first parents that will line up and call you to task if something happens, because academic institutions they're academic institutions. They're not 24-hour day, 7-day a week clinical health settings. And there are parents and families who expect that, and you have to kind of know where your limits are there. And with all these situations, there are dynamics that need to be assessed and judgments that need to be made. And let's face it, it's not a perfect decision-making process. So part of it is protecting what's in the best interest of the student, and part of it is documenting what you have to document to protect your institution, because at the end of the day, you can have an active safety net and catch 99% of the kids. That's going to go unnoticed. It's the 1% that falls through the net that are going to create issues, and then it's going to be important to make sure that you've done everything you can do and everything is properly documented, because that comes into play down the line in some of these unfortunate situations.
Yeah, absolutely. And I wanted to ask as well, because we had a poignant comment in the Q&A that says, I believe that proper space needs to be allocated to staff. It's also important just to have enough staffing. What's happening now is that the staff is just so overwhelmed that they aren't able to assist with this higher level of support. So I wanted to ask Hillary, from your perspective, how does this culture of risk mitigation, especially in context of we are already understaffed and overwhelmed, how does this affect the staff who are trying to do this student-centered care?
Oh, I think it affects staff immensely. The number of advisors that have consulted with me or just other folks on campus from any department, they are certainly carrying quite a bit of this load. You know, when they have a student who reaches out to them and says, I've missed class for X amount of time because of my depression, and then they start to disclose more information, and then some of those are like risky, and it could be a really scary opportunity or moment for a staff member, you know, to hear things and think, oh my gosh, like what should I do in this? That's a lot for a trained professional to be holding, let alone somebody who doesn't have that. And so anything that I think universities can do to help support their staff in increasing their confidence when it comes to handling those situations. I wish I could say comfort, but I don't know that comfort is ever the right word when it comes to handling that risk. But giving staff those opportunities is massive, whether that's mental health first aid or QPR or anything where they have a good concept understanding of how to support a person in that moment and how to get them connected to resources. And then they need debriefing. They need an opportunity to let some of that out and talk it through and just have it normalized. That was a really hard conversation, a really hard moment. It's amazing what happens just to have somebody sit there and debrief with somebody else who has just been supporting a student in a really challenging way. I think giving them the space, giving them the training is really critically important across campus.
Yeah, I mean that I really agree with you, and I think not just training, but also the support that comes after some of these critical incidents. Because when clinicians are burned out, when they are terrified, right, that is often when mistakes happen. And it is often a time clinically when we start leaning more into protecting ourselves versus really being student and patient centered. And so if we want to think holistically about how, like, what are all the different ways we can mitigate risk? One of the best things you can do to mitigate risk is take care of your clinicians so that they can do really, really good work. And make sure you have a good plan, policy, procedure for how you're going to support them in the event that a critical event does occur. Because when you lose a student to suicide, the last thing that you need to be thinking about is, am I going to lose my job as well? Right? Like, this is a person who's been doing very important, difficult work for your institution. And now is the time to step up and support them. So, we've talked a lot about the importance of policy and procedures. But I know that there are actually, even though the goal from Jeff's perspective is to, have more policies and procedures so that we can remove barriers, there are also some major barriers to confidence in these types of policies and procedures. And Daniel, I'm wondering if you could talk a little bit more about the research or lack thereof on some of this stuff that makes this work more challenging.
Yeah, well, I mean, I think being part of this conversation has made me think that there's some really valuable research projects that need to be done. And I don't know if some people in the audience maybe are involved in research or connected to research. So if you are, I hope you'll um, contribute to this. So I think one research project that needs to happen is to better document what the actual policies and practices are across a large number of institutions. It's I know that would be challenging because there's so much nuance here, and a lot of institutions probably have maybe a briefly worded policy that beneath it has so much more nuance, that's kind of case by case. But I think So it's going to require, I think, kind of a combination of maybe some quantitative data, but more qualitative data to really like interview institutions, figure out really what are they actually doing and how does it relate to what's written on the books. That I think would be really helpful. And then another type of project that I would love to see is sort of a compilation of all the case studies that are out there. Like each student, in a sense, is a case study. And could we uh, somehow compile a database, obviously with everything anonymized and no like identifying details, but a compilation of kind of the experiences that students have had in these situations and the experience that institutions have had in trying to support students. There's so much collective wisdom, but it's all out there kind of scattered and not being shared for a variety of reasons. But I realize all of this is just stuff that's going to help maybe 5 or 10 years down the road. It's not going to help tomorrow, but that's what research is. It moves kind of slow, but then can have a lot of payoff in the longer view.
I mean, yes, the research does move painfully slow, but it sounds like what you're saying is that you're maybe starting a new project and looking for some collaborators.
I'd be interested. I don't need to necessarily take the lead, but I think the field needs something like this. So yeah, I'd be happy to help.
Yeah, I mean, and I do think though that like, especially in a consortium type model where you're I mean, we know that, these true critical incidents, part of the challenge, as you noted, is that they don't actually happen that often. I mean, thank goodness they don't happen that often, but it is very hard to generate empirical conclusions when your N is tiny. And but that said, the process of doing our very best to learn from each case that does occur and sharing that knowledge and building that support in institutionally, it does sound like it would have some short-term impacts even before the long-term results are released. So as we get into the back half of this webinar, I want to turn a little bit more towards support systems now. And Daniel, I might ask you to kick us off again on this one. So when we think about our higher acuity students, we often think about crisis support as the intervention. And I'm wondering if we can talk a little bit about how crisis support maybe fits um, within a larger system of support that we might consider. That includes things like prevention and transition support, other types of interventions that we hope would reduce the likelihood of some of these things either happening in the first place or happening on a more chronic basis.
Sure. Yeah, that's of course a really big question, but I'll just offer a couple ideas. So I think every campus is struggling with this big question of like, what is the optimal system of support with the full range of prevention and treatment and crisis intervention? Um, and the good news, I think, is that there's an increasing array of programs and services that are that are different than just traditional mental health care, supplementary preventive services, a lot of digital mental health options, a lot of like peer programs, coping skill programs, courses that teach students some kind of preventive skills. So it's difficult to just make sense of what's out there. And part of what our research group is trying to do now is to sort of catalog what's out there, particularly preventive programs, and make it clear what the evidence is for various programs. So we're coming out with a series of reports along those lines. But to hone in on a couple threads, I think one that's particularly relevant to crisis prevention is early identification. And as everyone knows, campuses have for now decades been using various forms of gatekeeper training programs. I think the term gatekeeper training is going out of vogue a bit, and now it's maybe called more just mental health training, but basically training non-mental health professionals to better recognize signs of distress and then have a supportive conversation and help people get to care earlier. Um, One thing that I've noticed in the research with these training programs is that the outcomes are they're okay in the sense that it looks like people get trained in a lot of the programs, feel more confident and knowledgeable, but the outcomes are not great in terms of actual evidence of behavioral change. And I think what might be missing in a lot of the programs, training programs, is that they're just a one-time program. So my hypothesis is that if we can go beyond that to actually have a little bit more of a continuous or kind of repeated dosage of training, even if it's just simple a reminder of like, you had that training and remember to use it. And here are kind of some of the key skills that you learned. And it's to enhance that motivation to actually use the skills. I think the trainees will be more impactful in communities. The other thread to think about is screening and then kind of triage or filtering people into the right level of care. So I think a tiered system of support where you're identifying people's level of need on a regular basis and then getting them to the right level of care is a model that I know a lot of campuses are playing around with, but I think that's going to continue to evolve, and I think that's also going to be quite helpful.
Thank you. Yeah, I love prevention, and it's so hard, right? Like it is so hard to get funding to do prevention research, and it's really hard to prove that you prevented a thing from happening on any type of reasonable timeline. So it's like, this catch-22 of really, really desperately needed work that makes so much sense from a public health perspective and also just fraught with barriers. Of the programs that are available, are there any alternative programs or models that any of you all feel like are really worth the investment to be doing specifically on campus versus those that are really better suited for off-campus providers to offer?
I feel like mental health first aid has been something that's been really successful and just providing some education on just mental health in general, but then also how do we support students in this situation or what are some options here? I know one other thing, this isn't like a program you can purchase anywhere, but we ended up developing like a training on campus, our counseling department did, that's very campus specific so that we can talk about mental health and then, all right, if this happens, here's where you go and here's where you go. So they have the specific campus resources as well, which sometimes I feel like that's the part that can be missing in these bigger training programs is you do need your campus specific resources because you can have the meta level up here, but then we don't know where to send them like right in front of you. That can be a big disconnect. So some combination of the two, I think, is the ideal.
Okay. Yeah, we're getting a lot of comments in the chat right now, so I can tell this is top of mind for folks. And I think specifically on the question of like triage and reporting. So Paige is saying we have a whole triage unit to get students the right level of care. It has made a huge difference for our poor counseling center to give them some relief and space to breathe more. It works great. And there was another question that I think dovetails with that, which is like, okay, we have these high risk students, and most counseling centers operate on a brief treatment model, oftentimes 6 sessions or less. And so, curious to hear if you all agree with me, but where my head goes is, yeah, if you are not resourced to offer more than 6 sessions to each student, don't get yourself into that situation, because trying to do this work from a place of being chronically under-resourced is it's not good for anyone. What you can do is really good triage and screening and have supports for, okay, if somebody is really outside our scope of services, as much as we might want our scope of services to be different, what are we funded for? What are we resourced for? What are we policied for? Right? Let's do great triage work and have a great referral system in place to make sure that we hold the student while they're getting to that next thing, even though that next thing might not be on our campus. Okay. So one more question before we go for final thoughts and Q&A. Um, So, what do you think the role of the campus is in providing support during transition periods? So, even though we're not probably offering IOP on our campus, just as an example. I mean, maybe we are, but probably not. Probably not. There's a lot of transition involved, even in what Jeff was describing, right? Where it's like, if we're going to do a medical withdrawal, that means there's a transition out, there's a transition back in. And especially given that, like discharge from hospitalization, for example, is a particularly high risk period. Um, what is the role of the campus, if not providing treatment, in supporting those transitions? Are there best practices? Are there recommendations? What can we offer here?
At Case, we follow quite a bit from like the NABITA standards with BIT and care teams, and so that we actually use a care team meeting structure for students if there's been several care reports submitted with concerns about a student, or maybe they've been transported to the hospital, or we're aware of a hospital admission and discharge. They self-disclose that they're transitioning from a higher level of care to lower level, whatever the case may be. We try to offer a care team meeting, and that goes through our Dean of Students office. They initiate that meeting, but within the meeting would usually be myself or one of our care managers, a member of Disability Resources, the student's 4-year advisor, plus their dean. And then there's a what we call private discussion at the beginning of that meeting with all the parties there. How are we doing academically? What additional supports? What accommodations do we need to talk about? What faculty members need additional notifications or reminders to follow accommodations, if you will, variable questions, concerns that's stressing the student out quite a bit as they're transitioning, which is, you want to alleviate that as much as possible. They're already in a lot of distress if they're transitioning from a higher level of care down. So anything that we can do to help them be successful is huge. In addition to that meeting, once we talk about all the academic pieces, then we have everybody else hop off of it, and then myself or a care manager has the confidential discussion with the student where we also assess for risk and talk more specifically about their individual symptoms, needs, and additional care, and then bridge that care to them. If they're not connected to that next level of care, we'll bridge that until they get connected.
Absolutely. Anyone else have thoughts on this before we move to the next topic?
I think Hillary is right on the money there. By whatever term your campus calls it, a care team that provides, you need it. It runs a lot of times out of the Dean of Students office. There has to be dot connectors. Counseling centers don't exist on an island unto themselves. They have to be surrounded with a network of support. And that network of support extends throughout the campus, from RAs to RDs to security officers, the dining service workers who sometimes see students, more than faculty do, more than administrators do. So picking up on what Daniel mentioned earlier, training and gatekeeper training and getting everybody involved so that there's a network of support and people out on campus understand when the red flags are there, who to contact, when to contact them. And then there's a group of people that gathers around the needs of the students, and they need a point of contact, especially if they're transitioning out of the hospital back to the campus, from the campus home, from home to the campus. They need a point of contact so that somebody can help explain to them, the process and what the steps and what they're going through. And I think that really helps a lot. And by whatever term you call it, case managers or administrative people who are responsible for liaison with the student and the family. So.
Yeah, thank you. So I didn't write this question, but I was like just really excited to get to the end, to get to this question, just because I can't wait to hear what you all are gonna say. Um, so before we get into the Q&A, we wanted to do some final thoughts. And so for each of our panelists, I just wanted to ask if you could just offer one key takeaway, what would it be? Key takeaway for institutions, for the audience who's here today, what would that be?
I would go back to what I just noted. I think you need to have a well-developed network of support that spans multiple offices, that includes academic advisors, academic deans, student life people, counseling center people, health center people, um, uh, uh, that can manage your counseling concerns on campus in a way that uh, threads needles and understands the difference between clinical confidentiality and administrative confidentiality, two different things, and there's ways for those uh, uh, paths to work collaboratively together without violating the space that the counselors are in. So I think that probably is understanding. Go back to what we talked about earlier. People need support when they're dealing with these situations, and I think one of the best ways to provide that support is to have a well-developed network of support that kind of wraps the counseling center in extended administrative support so that they know they're not alone.
Love it.
I completely agree with you, Jeff, and I'll piggyback off of that a little bit with the networking piece. I have found it to be incredibly valuable to just really get to know the people in the departments that I might be connecting students to. Um, my confidence is so much higher when I say, hey, I'm going to hand you over here to Joe in this office. And like, I know him, and it helps the student feel more comfortable as well to actually really know those other people. And then we also share, hey, this part of the system's not working. Let's work on how do we improve this process, make it more efficient, less clunky for the student. Because the more barriers you can get out of the way for a student, the more likely they are to be able to succeed and get going in the direction that they would like to go in. I think that's a huge piece. I think ensuring that you have that nice work-life balance is so important to make sure that whether you are directly taking care of a student or supporting somebody else who is, that you can take care of yourself. Um, and then always keeping in mind the balance between the student's autonomy and the decisions that they have and what care they would like to receive and what they don't, balanced with what expectations does the university have in order for the entirety of campus to be safe and for everybody to be able to succeed in a safe environment. It'd be tricky in some cases, but ideally we can have all of those things there.
I'll add that I think one piece of our research that institutions have found most helpful is our piece where we've shown that student mental health is a strong predictor of whether students remain in college. And we translated that to essentially an economic case for investing in student mental health. So even though there's a lot of debate about what's the level of responsibility for campuses to address student mental health in different situations, I think there's no debate about the fact that if we can help students remain in college and eventually graduate, then that's consistent with the institution's mission. And our research and other research backs up that if you're doing something that's supporting student mental health effectively, then you are, in fact, helping students remain in college, and you are actually like implementing investments that are have returns to institutions, no matter what perspective the administrator might be taking.
Yeah, very important. Thank you. And I was trying to think of what I should say without sounding like a downer. But I think my key takeaway is really be honest with yourselves, as leaders, as clinicians, be really honest with yourselves about the reality of the work that you're doing when you're working with high risk students. I never want to lose a student to suicide. I never want our campuses to be affected by critical incidents. And there is a reality that no healthcare provider can save every life. No healthcare provider can catch everything. And so I think that when, as hard as it is, right? Because we don't want to feel like we're giving in or giving up, right? And I'm not advocating for that. But as hard as it is, I think we are better prepared to handle the needs of these students, the needs of the students in the aftermath of critical incidents, when we're willing to go there in our minds and really think through what is this going to look like, and what is the best, most student-centered thing that we can put into place to minimize the harms, to keep everyone as safe as possible, and if the worst should occur, minimize the harms. And I think when we hold an expectation that this will never happen, what inadvertently occurs is that we don't prepare well enough or honestly enough for when it does happen. So that would be my takeaway. And with that, we are going to jump into the Q&A. So really a good question here about academic and financial penalties. So regarding not attaching academic and financial penalties to taking time away from campus, some of these are unavoidable. For example, if taking time away pushes the student below the completion threshold for satisfactory academic progress for federal financial aid, how do we best help students navigate this?
Well, I'm not an expert on financial aid, and that's a complicated area in and of itself. But um, I think at the end of the day, um, I've at least found that some of the most pressing concerns that students have when they're trying to navigate a voluntary or involuntary separation has to do with financial penalties and academic penalties. And you could argue the same thing when the student's being suspended for conduct reasons. And I think there's got to be some flexibility in the financial aid model that allows for extenuating circumstances. But when we get past the time period, and policies are meant to be followed. There's got to be some consistency, but sometimes you have to break out away from that if it's in the best interest of the student. So if we were beyond the refund period, I would lobby and advocate and sometimes implement a 100% refund for the student for tuition, room, and board. Outside of things like consumption of actual food. And if they were past the withdrawal penalty for academics, one way to ensure that they're not going to want to leave is to saddle them with a withdrawal failure. So, if you can give them a withdrawal or an incomplete and be flexible with your policies. And then I think, again, I'm not an expert on the financial aid piece, but I've actually never seen a student get penalized from the financial aid office for not making satisfactory academic progress if there were extenuating circumstances that justified voluntary or involuntary leave of absence, which is totally different from a student that's not succeeding academically and faces that penalty. So I just think that at the end of the day, doing what's best for the student in that moment based on your judgment. And again, it's an imperfect decision-making process. You've got to make the best call you can based on the information you have and what your assessment of the student's individual and family situation is.
Yeah, so I mean, it's also, aside from the like weighing of individual factors, it sounds to me like this is very much a risk mitigation strategy that you can plan in advance for, right? Does your administration have a fund available that makes it easier to make these judgment calls when we're in a situation like the one that the audience member asked about, where federal financial aid is no longer going to be an option and the money has to come from somewhere? That is the thing we can plan for. All right, this is a hard question. I've done this one before. Okay, can you talk about how to best navigate situations where a leave of absence could be beneficial because the academic environment is a causal factor, but the family is known to be a detrimental factor? So what's the best place for the student if both home and campus are harmful? I hate this one.
Yeah, you are just stuck yes, there are students who are often in this position, like you can't win for losing, it's tough. And I think this is when you really collaborate with the student so that they are part of whatever that plan is. If it's going home, okay, what do I need to have in place so that I am safer at home, so that I have more support at home? Can we start that process earlier? Can we get you connected to a provider? Is there maybe an Al-Anon group or any other type of support groups that are in that area that could also serve as a point of contact for that student to go home to? And on the flip side, if it's something where, okay, on campus, what are the changes, depending on what the situation is, we're in accommodation of a single room. Would that help with the circumstances on campus? What about, parking arrangements, et cetera? There's so many factors that I think we can get really creative in these instances so that we can try to find a solution that is minimizing the most harm and minimizing the most risk possible. I think it's really, really hard to minimize all of it. And I know that every risk mitigation lawyer would hate that answer, but there's just an unpredictability of just people in general. And I think the more we collaborate and plan with the student, the better an outcome we're going to have, because they're not trying to figure it out on their own, which has been part of the problem, I would guess, in a situation like that, because they've been navigating a lot on their own.
Thank you. Yeah, and I think we have time for just one more question. There's a screening question. I'm wondering if this might be a good one for Daniel. Are there questionnaires to help students understand if they do need a higher level of care? In many cases, it's also about self-identifying if a higher level of care is needed. So something, on the measurement perspective around like, are there screening tools that we can use to help parse this out? And, perhaps also help students themselves, understand and be more accepting of what their needs might be.
Yeah. I mean, there are obviously a lot of clinical screens, like screens for depression, anxiety, disordered eating, suicide risk. Um, I don't think there's like one best screen. An example of a commonly used screen is, as many of you know, the PHQ-9 for depression. Um, or there's a PHQ-2, a 2-item version. But I think I wouldn't those are kind of the scientific screens, but I wouldn't dismiss also there's another type of screen which I think some campuses are using, which is really more about like what do you want, or what's on your mind, or what are you looking for help with. It's more kind of student driven in a sense. It's and I think that for many students might get closer to more quickly to the real issue, like because it might not be for them. They're not thinking in terms of depression or anxiety. They're thinking maybe in terms of financial stress or peer relationships or like academic distress. So I think the optimal screening system would be brief, but and would have a combination of maybe some symptom measurement, but also like just simply asking the student, what are your main concerns? And then I want one last point on this, which I think Jeff was talking about earlier, is the value of connectors, not just for students in crisis, but for students in general. They have a hard time in many campuses making sense of all the resources that they might connect to. So a navigator or a connector of some case manager, that type of role I think needs to exist for students across a wide range of contexts.
Yeah, I definitely agree. I think Jeff described it as like there has to be that point of contact, right? Like it's so much easier with all the possibilities for what a person might need, what they might access, if you can at least give them a single entry point that helps them navigate, that can just really de-stress that experience. We have 2 minutes left. Daniel, we have one more question for you. So, uh, the screening that you were just referring to, that's more,
Mhm.
maybe a little bit more student driven. Do you have any recollection of what the name of it is?
There's not one in particular in mind. I've seen versions of it. I will try to find a specific one that I can then send to Mantra Health to then
Yep.
include in the debriefing materials, because I don't have one specifically in mind. It's just kind of
Okay.
a general concept that occurred to me.
Yeah, no problem. Well, so we're coming to the end of our time together. Before we close, I do want to thank everyone for being here. Thank you to our panelists. This was an incredible discussion. For those of you in the audience, please do take a minute to fill out that end of webinar survey. The questions that you ask literally help us to put on webinars that will be relevant and useful for you. So that feedback, it really does get used and taken seriously. And we will follow up with some resources. We'll circle back with Daniel and make sure we follow up with some resources and materials for those of you who are here. So thank you so much for spending your hour with us, and have a fantastic day. We'll see you all next time. Bye, everyone.